Thank you so much for joining our Urology What You Should Know webinar. My name is Alicia Chowdhury, and on behalf of the Core Kidney Program, we are very excited to have you here. Next slide, please. So I am actually the outreach director for the Brew and Beans Health Club, which is an undergraduate organization that partners with Dr. Anjay Rastogi and the Core Kidney Program. And being a part of this community has been one of the most meaningful aspects of my time as a student. And what makes Core Kidney so unique is that it does not treat healthcare as something that is abstract or removed, but it brings the human experience to the forefront and centers real people as patients, donors, and caregivers. And what Core Kidney truly asks is how do we make sure their voices are not only heard, but truly valued? Next slide, please. As outreach director, I've had the privilege in planning and coordinating many successful initiatives. Here at the Brew and Beans Health Club, we lead these outreach initiatives all across the greater Los Angeles area with a special focus on underserved communities and organizations. Our mission is not just to provide resources, but to, in fact, provide a lasting impact on these different communities. Through our collaborations with Core Kidney, we've been able to expand our community health programs and connect vital resources with the communities and people that might not otherwise have them. At the heart of our outreach is a commitment to empowering patients and helping them feel confident in advocating for their own health. Next slide, please. I would like to highlight one of our most successful outreach events that CORE has put up in the past year, which was the 2025 Rose Parade. It's in your hands. This was a resounding success at the Rose Bowl, and we really increased our kidney health awareness on a national scale, and it was a very impactful and fulfilling event. Thank you so much to all that were involved and watched us on this tremendous day. Next slide, please. I would also like to highlight the core values that we embody in all the work that we do. As you may know, CORE actually stands for Clinical Excellence, Outreach, Research, and Education. And each of these pillars does, in fact, show up in very real ways throughout our programs, each of which will be highlighted in our presentation today. Next slide, please. And I would also like to extend our heartfelt thank you for everyone who was interested and supported us in our very first patient summit this past fall. We sincerely appreciate your engagement and your commitment to advancing our education, information sharing, our community, with our support in our community as well. Our patient summit brought together a great group, including patients, kidney donors, supporters, families, providers, and also industry experts. Our goal here at Core Kidney is to empower individuals at events like these. And those families and patients that are impacted by kidney disease, they benefit the most from events like these. And they're remembered for years after. And we hope to continue putting on events just like this to really connect with our community and bring light to what matters most to us. Next slide. Here, I want to take a moment to highlight the people who make all of our outreach possible, which are our core kidney ambassadors. These are kidney transplant recipients and living donors who have chosen to give back to their supporting patients and families who are facing the challenges of kidney disease. And their lived experience allows them to connect not only on a deeper and personal level, but also they offer guidance with their roles and continue to give us all hope and inspiration. This is our Brew and Beans Health Club, which are all the undergraduates that help us make these events happen in tandem with Core Kidney and the Circle of Core. Each of the beings on this screen here are doing great work within their undergraduate career to help push forward the mission of Core Kidney. Next slide, please. To finish off my portion, I really want to highlight the Green Ribbon campaign as we are also closing in on March, which is National Kidney Month. So this initiative actually started right here at UCLA through the Core Kidney program, and it has grown into something much bigger than just a symbol. I would even go as far to say that this is a movement. Right now, over 31 million people are diagnosed with kidney disease, and another 26 million are at risk. And these numbers are very, very massive. And honestly, they're a reminder of how often kidney health can get overlooked before it is far too late. That is why awareness matters. The best way we can fight kidney disease isn't just through treatment, it is through education, it is through catching risk factors early and empowering people to advocate for their own health before they reach a point of crisis. And that is where the green ribbon comes in. Wearing a green ribbon is a symbol and an act, but it carries so much more meaning. It signals that you care and that you're paying attention and that you're helping push kidney health into the spotlight where it deserves to be. Awareness like this saves lives, and this campaign really does make that visible. Next slide. This is our disclaimer for the program before we get into the educational material. Next slide. And this will begin the educational portion of the webinar. It is my pleasure to introduce to you our core kidney faculty and our speaker for the evening. They bring a wealth of knowledge and experience to share with us, and we are very excited to learn from their insights and expertise. Next slide. I would like to highlight Dr. Michelle Huang, who is one of our new core kidney faculty here. She is the Associate Director of Core Kidney and is a board certified nephrologist. She has her clinical expertise within hypertension, chronic kidney disease, kidney transplantation, and preventative nephrology. Additionally, she is fluent in both Korean, Japanese, and English, which helps her connect with a diverse patient community as well. Next slide. I would also like to highlight another faculty of ours, Dr. Sean Lei, which is a board certified physician in internal medicine and is one of the new faculty of the UCLA nephrology team. Dr. Sean Lei is located in Burbank for any patients who need to receive care in that area. And he is looking for new patients as well, and his dedication to advancing kidney health and improving patient outcomes has shaped both his clinical work and academic pursuits as well. Next slide. And now I'm very happy to introduce the speaker for today's webinar, which is Dr. Fahad Sheckley. He is a board-certified nephrologist with the Hackensack Meridian Medical Group and is practicing in North Bergen and Hoboken, New Jersey. He has completed his urology residency at the Hackensack University Medical Center and earned his medical degree from Oakland University. Additionally, he received his undergraduate degree from the University of California, Los Angeles, where he gained early research experience in nephrology at the Ronald Reagan UCLA Medical Center. So he is very close to home for us here in SoCal. And Dr. Sheckley also specializes in surgical management of a wide range of urological conditions, including kidney, bladder, and prostate cancers. And he will go into explain how this all can relate to kidney disease and etc. I will now have Dr. Rastogi highlight one of the patients that also was impacted by Dr. Sheckley so deeply. Next slide, please.
So thank you, Alicia. So hi everybody. Thanks for joining us on a Sunday. We have a pretty good attendance here today. So today it's a very special chat. It's very special for me and Christina actually, because Dr. Sheckley was and is a part of Core Kidney. Actually, he was a part of the Core Kidney when it was not even officially called Core Kidney. We were just a program at UCLA with no defined name, but we're doing all the same things that Core later defined. And Dr. Sheckley came in. He's an undergraduate at UCLA. Actually, we covered his story in one of the interviews. The Beans did that, and that will be posted on on YouTube and social media. A very, very inspirational story, to say the least. But Dr. Sheckley joined, he was an undergrad at UCLA, and then he also started doing research uh, with us and was study lead on many of our studies that actually were very impactful and led to the first and only to date PKD drug. And this is an email from one of the patients that came in. She got this email invite, and this is what she said. I cannot attend this chat, but I wanted to send a very big hello to Dr. Sheckley. He was one of my very first research assistants when I was in the tolvaptan, a drug called Genarcu now was approved by FDA. After that, I doubt he'll remember me. Actually, he does. We spoke to him, and he actually remembers the patient very well. But please pass along my congratulations and well wishes to him. So I just and she actually was transplanted in 2023. So at UCLA, Dr. Sheckley, was doing research in nephrology and then decided to take the surgical side, and he will go over the difference between urology and nephrology. But he's a very accomplished surgeon, obviously very bright, but what really stands out for me at least, and I know Christina will say a few words too before we have Dr. Sheckley go over, his presentation, is the kind of human being Dr. Sheckley is. And, he's an exceptional person, kind, um, helping everybody that he can. And this email is just one of many comments that I received directly from our patients. So this is a very special chat. I'd reached out to Dr. Sheckley and I said, we have never done a urology chat. We have done on kidney stones. We did a symposium actually, but it was not for patients, it was for healthcare. But we never did a chat on urology. So this will be your time. It's mostly non-transplant because we want to focus. Transplant is a very different beast. If there's some specific questions, you can ask them, but we'll be focusing on the non-transplant aspect of urology. So please do put in your questions, ask your questions, keep it interactive. If we're not able to answer all the questions, we will definitely get back to you. I do want to point out a couple of the people over here. We have Brian Gillum, our lead ambassador for Core Kidney, a kidney donor himself, is joining as well. We have Dr. Michelle Huang, who is the associate director for the Core Kidney program and very involved in all aspects of core kidney research. And then I will hand it over to Christina. He definitely would like to say a few words, and then we'll have Dr. Sheckley come over. So thank you once again for attending.
Absolutely. I'm so excited. We've been looking forward to this chat for a while now. When Dr. Stogie told me that Dr. Sheckley was had agreed to speak in February, I was waiting for the day, and today's the day. So, um, Dr. Sheckley is very special in our office. We started about the same time, and he was very just so caring and just such a wonderful human being. I mean, we know him when he was an undergrad, and then he started working in our office, and now he's a physician, and so now he's teaching others. I mean, he took a lot of core with him. Is I guess that's what I'm trying to say. And he's just an excellent human being and an excellent doctor. So I have a lot more things to say about him, but he needs to start his program. So thank you, Dr. Sheckley.
Thank you all. Thank you so much for your kind words. I mean, I'm truly blessed to be part of you guys. Good evening, everyone. I started with UCLA with Dr. Rastogi and Christina in 2011, and it's been um, the best experience that I've had. Really, it was an experience that shaped me, and the interaction with the patients. Of course, I remember the patient who wrote that letter, which is which is like, it makes me really happy, because if I had any impact on any patient, then I would be the happiest person in this world. But um, when I started in 2011, I had no idea what kidneys were. I was still an undergrad, and I worked with Dr. Rastogi and with Christina for 4 years before I transitioned to went to medical school. And learning so much about the kidney really made shape my life on a personal level. That's how I decided to choose urology as a career. I kind of had a passion for surgery, but I also had a passion for kidney health, which was really taught to me by Dr. Rastogi, who was really encouraging me to learn a lot about the kidney, and I did. And I have to say, my biggest teacher throughout this journey was the patients I interacted with. And especially, I worked mostly with polycystic kidney disease. And yeah, it's been an amazing journey. And I'm so happy to be here today with you guys. So today, I kind of want to highlight what urology is and the connection between urology and nephrology. This is always kind of confusing sometimes for patients on when do I go to a urologist, when do I go to a nephrologist. It's honestly confusing to even some medical professionals out there. So a nephrologist is, so the kidney is a filter, and anything that there's a problem with the filter, then especially before the fluids get filtered through the kidney, or the kidney is unable to filter these fluids, then that's a nephrologist. So, but my job as a urologist is usually after that filter, after the fluid is filtered, what happened to that fluid, if there's any problem, then that's a urologist. So we like to call it pre-renal in like medical terms. Pre-renal is nephrology, and post-renal is urology usually. So next slide, please. I have first I have no conflict of interest, but so as I said, kidneys are an amazing filter. It's the best filter that was made, and they are, if you think about it as a water filter, and the in the top, and then you see these tubes and the bladder. These are the plumbing system for that filter. So the kidneys, obviously, blood will come into the kidneys and gets filtered. And once the urine is filtered, it collects here in the middle of the kidney on both sides, and then it comes down these ureters. It's called the collecting system. So the urinary tract are the ureters, come down all the way to the bladder. The bladder is basically a muscle bag that pushes the urine out. In men, there's a prostate. So usually below the bladder, around the urethra, there's a gland called the prostate, and that's before the urethra exits. In women, there's no prostate, so the bladder goes right away into the urethra. Of course, there's something called a sphincter that controls our voluntary way of controlling the urinary output. So when the filter and the plumbing work together, everything flows smoothly. And that's why urologists and nephrologists, when they work together, and we have so many overlaps, the patients are happy afterwards. Next slides. So what we'll cover today is when the plumbing gets clogged or blocked. That's a urologic problem. There are many reasons of why the ureters might get blocked. First, the most common is kidney stones. Kidney stones are a very common reason of why the ureter sometimes is unable to drain the fluid. So if you see in the image on the right, there's backed up urine, the yellow, that's called the collecting system. And there's a stone over here in the middle of the ureter. When that blocks, so that means the kidney is working fine. It's filtering fine at this point. But the problem is, where is that filtered urine going? So when that backs up, it creates problems, creates pressure in the kidney that could affect the kidney function. And that's when the urologist has to come in and to drain or to open up that drain in order for that backed up urine to come down before any damage to the kidney happens. Next slide. Another reason or urologists cover is something when the filter changes shape. So the filter is working or and everything's fine, but sometimes there are issues that could happen to that kidney. For example, polycystic kidney disease, or when there's a mass, a tumor, whether it's benign or cancerous, there's something that's growing in that filter. The kidney is working fine, but that tumor is kind of getting on the way as well. Next slide. So when the plumbing gets clogged, the ureter, it's almost like a garden hose where you step on it. The water is not going to go anywhere. So our goal is to remove that blockage. The backup, as I mentioned, causes pressure and swelling in the kidneys, which can be painful. And if it's not treated, then it could lead to a damage in the kidney. That damage, usually, if caught early, is usually temporary. But if it's not caught for a while or ignored, that damage could be permanent on that kidney. And the blockage can happen anywhere in the kidney. It could be happening in the beginning of the ureter all the way down to the bladder. And then even after the bladder, it could come down on the way of the bladder coming out through the urethra. In men, especially very common, the prostate gets enlarged over time. It's one of these glands that keep getting bigger as we get older, and it could get on the way of plumbing the kidneys and the bladder, and that could create problem. Next slide. So, as I mentioned, kidney stones are the most common type of blockages that we see. They're basically hard pebble-like pieces that form from calcifications, or there are some other types, but most commonly calcium-based stones. They could form inside the kidney, and then when they get out to the collecting system and they make their way out, usually if they're small, they can pass. When they're like microscopic, they could pass easily, but when they become large stones, that's the problem. That's when they get blocked. As mentioned, enlarged prostate in men is a very common reason of blockages as well. The problem with the prostate enlargement is that it doesn't cause problems usually immediately, but only when ignored. After a long time of blockages, sometimes what we call a urinary retention is when the bladder is unable to drain anything. So both kidneys at that time will get affected because the kidneys are trying to drain, but because of that backed up urine in the bladder, nothing is coming down. That creates pressure on the kidney and creates a problem. So that will need to be addressed and drained. Sometimes scar tissue could happen in the ureters or anywhere in the collecting system, maybe because of previous surgery, or maybe because of an infection, or maybe because it's even sometimes some autoimmune diseases, or sometimes it's congenital where there's like a tightness in the ureter. These are all reasons that we see a lot as well for reasons for blockages. And finally, tumors. Tumors can press on the kidney. So tumor is not necessarily something cancerous. It could be any growth that could block the kidney, whether from inside of the tube or from outside of the tube, putting pressure, as I said, almost like stepping on a hose. These tumors could be even cysts that could block these ureters. Next slide. So what does a blockage feel like? Usually the kidneys, when they get swollen or when there's backed up urine, the kidneys are very sensitive. You're actually gonna feel very sharp pain. And I've talked to women who have like childbirth, and they always describe it as it's even worse than giving birth. This kind of pain is very prominent. Kidney stones pain is one of the most severe types of pain that a human being can endure. And that's why sometimes, people will present to the emergency department right away for this type of pain. There are sometimes they could have trouble urinating, if that how like feels blockage in the prostate, especially. A weak stream, feeling you're not able to empty the bladder, and also going more frequent. Other reasons is nausea and vomit. Other symptoms, nausea and vomiting, especially in kidney stones. We see that a lot. They're very like they come in with they're having refractory. Nothing is helping. They cannot tolerate any um, diet, like even water. They cannot tolerate sometimes. Sometimes, if that urine gets blocked and nowhere to go, bacteria could thrive in that environment. It's what we call stasis. It's the urine stays in the same place for a while. Bacteria love that environment and grows in there, and that causes urinary tract infections. And if it gets to the blood, it could lead to a blood infection as well. That would lead to systemic symptoms like fevers, chills, signs of infection. Next slide. So how do we find the problem? This is what we call a CAT scan on the right, and you can see that kidney is swollen. You see there are two kidneys, one on each side, and one of them is swollen. If you see in the middle of the screen, there is that white thing on the CAT scan. This is a stone. This is a stone blocking the kidney. This is actually a picture from one of the patients in our hospital. So you can see how blockage could lead to swelling of the kidney, and that causes that severe pain. So the best study is actually a CAT scan, which is almost like a glorified X-ray. Another study is an ultrasound. We can see the swelling. Sometimes it's not good at picking up stones, but it's very good at picking up swelling in the kidney. There's MRIs and other tests, but these are the two most common. Next slide. How do we fix the blockage? Well, sometimes if it's sometimes we temporize the blockage. We don't treat the stone right away, or we don't treat the enlarged prostate right away. We have to kind of first make the patient feel good, or drain that blockage. We drain that kidney or the bladder. That could be by a Foley catheter, or it's another name for a urinary catheter that goes into the urethra in women and in men, and that to drain the urine that's trapped in the bladder. In terms of the kidney swelling or kidney blockages, there are two ways of fixing that blockage. First is we put something called a ureteral stent. As you can see, it's a tube, that white tube that goes from the bladder all the way up to the kidney, and that kind of bypasses the stone, pushes the stone aside to drain that urine. And it's almost like a heart stent, but this is usually temporary. We usually remove it after a period of time when the patient is stabilized, and to treat the stone, and then we remove the tube completely. Sometimes the tube maybe cannot go in for whatever reason. The blockage is very severe, or there's something blocking it even from outside. Then at that time, we bypass the ureter and we put this bag on the side of the kidney. That's called a percutaneous nephrostomy tube. That means it's through the skin, and we go into the kidney and drain that urine. Next slide. So kidney stones are very common. They kind of are very common usually at the end of summer, when people are respirating and they don't hydrate themselves very well. Sometimes it's genetic, sometimes even if the patient is hydrating themselves, but they still form stones. It's a mineral. It's formed from mineral, mainly calcium. That's the most common type of stones. Small stones, sometimes we let them pass. It's called medical expulsive therapy. But if it's a large stone, then we have to probably go in and then try to relieve that pressure and break the stone. How do we break them? So there's something called shockwave lithotripsy, which is laser from outside, when the patient is basically laying on their front and the back is outside, and then we start shooting from outside through using X-rays. That the problem with this one is that what we call a stone-free rate, in which we clear the stones completely, is usually lower, because you're just breaking the stone with the hope that these pieces pass by themselves. The better technique is called ureteroscopy. Ureteroscopy is a scope that goes into the ureter, and it's a tiny camera. and that treats the stones with laser. We usually break the stones with laser, and we can actually even pick it up with a basket and remove it completely. For bigger stones where a ureteroscopy might not be, the tiny camera might not be a good option, then we go percutaneous surgery, which means that we go in from the back of the kidney and with a larger camera make a small hole in the skin through the kidney and break these stones. This is usually reserved for very, very large stones that could take a very long time with the ureteroscope to treat with the minor laser. So these are ways to treat kidney stones. Next slide. So we talked about blockages. There are so many other reasons of blockages. As I mentioned, there are congenital, which means that the patient is born with it. So at that time, maybe we have to surgically go cut wherever it's scarred or wherever it's blocked and reconnect the tubes again. There are surgeries that we do for prostate to kind of relieve the pressure, open up that blockage down there in the prostate. If there's any bladder tumor that's causing blockage in the output of the kidney into the bladder, we remove that bladder tumor and open up. But there's other things that urologists do other than blockages. It's when the filter changes shape. We're talking about cysts, sometimes polycystic kidney disease. Some patients might have very, very large symptomatic cysts. There are renal masses or tumors that are maybe not polycystic kidney disease, but one cyst is forming, or a tumor that's could be benign, could be cancer. So we have to remove either the entire kidney if the entire kidney is affected, or part of the kidney if part of the kidney is affected. Next slide. Polycystic kidney disease, a very common thing that we deal with, especially with between nephrology and urology. It's mostly a nephrologic problem until it becomes a problem where pain is severe, or if there are certain conditions where we intervene. Autosomal dominant kidney disease is the most common type. It's hereditary, which means it's inherited. It's caused by a mutation in one, and there are two genes, PKD1 and PKD2. If a parent has a polycystic kidney disease, which is autosomal dominant, then there's a 50% chance of passing the gene to each child. Okay. Onset, usually symptoms start developing later in 30s, 40s, but they can even appear earlier. Sometimes they don't appear at all. Sometimes I've seen patients who had a CAT scan for something else they didn't know until they were 60s, and they found out that they have polycystic kidney disease. So it is happen, and there's a spectrum of the severity of these diseases and their influence on their kidney function. Cysts grow on the kidney and can develop to other organs like liver, pancreas. Complications, usually people find out that they have high blood pressure at such a young age, and what's the cause? Further workup might lead to that. Back pain, blood in the urine, they could form kidney stones. Some of these cysts might cause blockage of the kidney, and as I said, the urinary stasis, or the urinary, when it backs up, it could form kidney stones. It is a progressive disease that could lead to any problem in the kidney in the future. And that's why Dr. Rastogi and other investigators are trying to figure out a treatment for it. This is the disease that actually kind of got me interested in the first place in urology and in nephrology in general, and kidney health. I worked a lot with this disease during my time with Dr. Rastogi at UCLA. Next slide. There's autosomal recessive, and that's not as inherited as as prevalent as the autosomal dominant. It's a much rarer type of disease. Only if both parents are carriers of that gene, and even if they're both carriers, only 25% of their kids will have it. The onset is usually very early, and it's a little bit more aggressive and progressive than a dominant type. Next slide. Acquired cystic kidney disease. This form is usually not inherited. It's developed later in life. It can develop in individuals on dialysis. It is something that we see sometimes. These cysts form in dialysis patients, and they require monitoring. Some of these cysts might grow to become something more serious, and we basically, for urologists, we see these a lot, and we have to basically repeat ultrasounds or imaging at least every year to make sure that they don't become something serious. Next slide. There's something called the Bosniak classification of renal cysts. The way that we look at renal cysts, most of the cysts in polycystic kidney disease are benign cysts. The majority are something we call Bosniak 1 or even 2. So Bosniak is a radiologist, actually. He was, I believe he was in New York City, who came up with this classification of these cysts. So as you can see in 1, they are not malignant. They are very simple cysts. They do not have walls inside them. It's just a cyst that's filled with fluid. If you look at number 2, Bosniak 2, it's also a benign cyst. There's very micro calcification that almost becomes like a single septum that divides the cyst into almost 2, but that's usually also benign. And then it becomes more complicated. But there's Bosniak 2F, which has more septum, more separations. The septum is still thick in 2F. Only 5% of these cysts could become malignant. And then 3 and 4 are very serious. These are usually, we recommend removing the cysts. Usually we cannot just drain the cyst. We have to remove it in one piece without invading the cyst itself, because that could spread any cancer. The Bosniak 3 is 50% chance malignant. If you see the separations, the walls are usually more thicker. And Bosniak 4, they're very thick, and it doesn't seem like it's a simple cyst. This is something that has to come out. Next slide. What does PKD feel like? Usually the kidneys will get large, some people might get pain, might get pressure, might put on the muscles and the back muscles, and it's a very sensitive area too. They could put pressure on the nerves on these muscles, and that causes severe pain. Usually the pain is some type of pain that comes in the side and what we call the flank, and that could radiate or move into the groin region. Blood in the urine can happen if some of the cysts inside that are touching the collecting system burst. They feel full all the time. These large kidneys are pressing on the stomach. There's no room for the stomach to expand. High blood pressure, because they're putting pressure on blood vessels as well. As mentioned, they could become infected. They could form kidney stones. And that's what PKD could feel like. Next slide. Usually, if it's severe pain, if it's 1 or 2 large cysts that are obvious on imaging, we can remove them. Again, depending on the Bosniak classification, if it's a simple cyst, we can just drain it. We can just even put our friends from the interventional radiologist, they can put a drain through it and drain it with a needle sometimes. And sometimes we intervene, we remove the wall of it completely of that one cyst. We do not recommend removing all the cysts in the polycystic kidney disease because they're multiple and they could form again. But the large cysts that are symptomatic, we recommend intervention. Some of these cysts might get infected, and at that time, we definitely need strong antibiotics and drainage. And in some situations, a kidney removal is warranted, especially if the kidney is not functioning. If it's uncontrolled pain or recurrent infections, then we kind of remove it. Sometimes if the patient is getting a kidney transplant, we remove these polycystic kidney disease to create some space in the body for a new kidney. Next slide. Yeah, when kidneys need help, transplants. Urologists are not the transplant surgeons. There are transplant. Some urologists they do specialize in transplant surgery, but now there is a specialty in the United States, which is the kidney transplantation. Usually, they're not urologists most of the time. But how does the urologist help? Well, urologist, we do the living kidney donor nephrectomy, or the removal of the kidney from a healthy donor to give it to the transplant surgeon to transplant it in a affected or diseased patient. Sometimes the urologist might intervene to remove the polycystic kidney disease to create room for the transplant surgeon to transplant the kidney. We also want to make sure that the plumbing is working, because even if you put a transplant, if there's a problem with the plumbing, whether it's the ureter, what's in the bladder, or prostate, I've done so many procedures to relieve enlarged prostate prior to transplant, because the transplant surgeon is concerned that if I put a transplant kidney and the bladder is going to not drain very well because of an enlarged prostate, then that's not good for the patient. So sometimes we relieve that pressure before transplant kidney. Next slide. When to see a doctor, a urologist. Well, severe pain, as mentioned. Pain when you urinate, frequency with urination, urgency with urination, waking up a lot at night to urinate because you're not emptying your bladder, maybe. Visible blood in the urine, that warrants intervention. Fever with back pain, that could be a stone or any blockage that could be causing this problem. And a sudden change in your ability to urinate. I mean, sometimes maybe everything's fine, and then all of a sudden, we see that a lot after surgery, spinal surgery, where patients get a strong anesthesia, and then after the anesthesia, they cannot urinate because the bladder is still. It's one of the last things to wake up after anesthesia is bladder. So we see that a lot after spinal surgery, especially. So early detection and treatment is definitely key to protecting the kidney health. Sitting on a kidney problem is not good, because the kidneys, they recover very quick, and the earlier you find a problem, the better outcome eventually. Next slide. That's it. Thank you so much. I would leave the stage for any questions.
Of course. Thank you so much, Dr. Sheckley, for that extremely comprehensive and detailed presentation. I know a lot of patients really care for this level of detail and understanding their condition. And honestly, the difference between urology and nephrology is not often made clear. So thank you so much.
Yeah, absolutely.
We do have a few questions to address. From
Okay.
our chat today, we have a question that says, how is prostate health monitored over time if the urine stream stays consistently fairly strong?
Good question. So if it's strong, usually we treat symptoms. So it doesn't matter how big the prostate is. I've seen, so prostate size is normally in men between, let's say, 20 to 30 gram. Okay. I've seen patients with a 200-gram prostate. 200. That's over 7 times the normal, and they're still peeing very well. So the way we monitor that is symptoms. How many times are you waking up at night? It's a very common question. I ask my patients, how often do you go to the bathroom? Do you feel like you're emptying? And then sometimes we do a bladder ultrasound, what we call pre-void and post-void, which means that before they pee, I have them drink a lot of water, and then they come into the clinic. I do an ultrasound, and we see, let's say they have 300 cc in the bladder. And then after that, I ask them to go to the bathroom, pee, and then come back. I do another ultrasound in the same day, and to see how much they emptied. If they emptied and they had like only 20 cc, 0 to 20 cc, that's great. They're emptying very well. Even 50 cc is fine. Maybe they need to empty the bladder better. But if there's 100 cc left behind, that means they're not emptying very well. And that could be because of an enlarged prostate or something blocking. That's in terms of benign enlargement. We also check for men, we check the PSA, which is a protein released by the prostate called prostate-specific antigen. This is something that should be 4 or less. If it's more than 4, then indicates a problem in the prostate that needs to be addressed.
Okay, thank you.
Yeah.
Moving on to another question, we have what are some dietary modifications people can make that are recommended for those that have kidney stones?
Yeah, kidney stones is definitely diet influenced. Hydration. That's the number one cause of kidney stones is dehydration. As I said, it's the most common presentation after summer. Usually in August, September, October, you see a lot of patients. They had fun in the summer. They went to the beach, but they didn't hydrate throughout the process throughout this time, and that create calcifications that almost come together. These calcifications, calcium comes together, and then they form a small stone. The small stone could become a bigger stone, and then when it passes, gets stuck in the tube. That's so. We usually recommend drinking water about 2 liters, and in the summer 2.5 liters, which is about 4 to 6 of these 16-ounce bottles. Okay. Coffee doesn't count as a hydration, right? Because coffee makes you urinate more, so you might dehydrate more. So it's very important to kind of drink water or similar. Um, Low sodium diet. Sodium is definitely affecting the metabolism of the kidney of the stone. So it's definitely low sodium diet. We recommend about 1.5 to 2 grams of sodium a day. More than that, that could cause problems. Um, Other things is there's something called oxalate. Oxalate is the most common type of stones called calcium oxalate. So, diet that has rich oxalate, like nuts, leafy vegetables, and stuff like that. Usually, they have for people who are stone formers, we kind of tell them to try to avoid nuts and stuff like that. But then the problem is that leafy vegetables are good for something else. So I never tell my patients for with kidney stones to avoid leafy products, like green leafy products, but I tell them to hydrate while they're having this. There are other things. So, opposite to what people think, calcium is actually not something that will you should avoid. In fact, you avoid calcium, you might form. It's a little bit complicated, but but something like calcium might lead to more forming. If you avoid calcium, you might form more stones. It's kind of opposite to how you think about it, but don't avoid dairy products if you have kidney stones. Yeah, so these are diet modifications, but hydration is the number one recommendation.
Absolutely.
Mhm.
And I think regarding hydration as well, lots of people also consider supplements in terms of their care. Can you talk a little bit more about are prostate supplements effective? I think one was mentioned specifically palmetto.
Saw palmetto, yeah. Saw palmetto
Mhm.
is something that we don't prescribe. It's available over the counter. It's something that you can go to CVS, Walgreens, Costco, that you can get it over the counter. Saw palmetto is a herbal supplement that has shown out of all the supplements. Usually, as a urologist, we basically we follow evidence-based medicine, right? So there's not a lot of herbal stuff that are supported by evidence, except for saw palmetto actually is supported by evidence-based medicine. Um, but it's not as good usually as medications that we prescribe. But saw palmetto is known to help with relaxation of the prostate. It relaxes the urethra to make you empty the bladder better. Yeah, so that is something that usually sometimes we recommend, you know, doing in case the patient is refusing medications.
Okay. And for another question, I think we had some questions regarding PKD specifically, regarding
Mm-hmm.
when and what symptoms require the intervention for a cyst during PKD.
Yeah, so as mentioned earlier, pain, usually a lot of pain, and we're not talking about mild pain. We're talking about severe pain that requires intervention. Because remember, intervention is not something easy, right? It's surgery. So we usually recommend it for people who are not medical pain management is not working, at that time um, we might consider like draining that cyst. If that cyst gets infected, or if the cyst becomes complex, remember we talked about the Bosniak classification. If the cyst becomes complex, then we do recommend some intervention to remove it. But most cysts in polycystic kidney disease are benign. They are simple cysts. So only if it becomes very large to the level where it's blocking something, it's putting pressure, especially on the left side, it might put pressure on the stomach. And that could cause early satiety, or you feel like you're full and you can't like tolerate anything. You have small amount of food and you feel full. Sometimes people vomit because of that pressure from a cyst into the stomach.
Okay, thank you. We have a little bit of a more specific question from a caregiver in our
Mm-hmm.
chat today. They have
Yeah.
expressed that their daughter is 13 years old and is diagnosed with an atrophic right kidney, and it is smaller and only has 18% function. They tested urine reflux, but she doesn't have any, and she tends to have frequent UTI. She's additionally also diagnosed with high blood pressure and under medication, and the blood pressure is now under control, but they don't know what the cause of her kidney to shrink is and what the cause of frequent UTI is. From that limited
Yeah.
insight, do you have anything to share?
Sorry, so you mentioned the reflex study was negative?
Yeah.
Okay. So sometimes there's no explanation. We don't know why as one kidney is not working versus the other. We've seen that a lot where some people having one kidney that's working just fine and the other is atrophic, which means atrophic means it's small. It's not. So sometimes we do something called a renal study, which, as you mentioned, she has 18%. A renal study is a study that we do to determine the function of the kidneys. Now, if that kidney is not causing her any problems, we usually don't do anything. If the kidney is causing her problems and the kidney function is very low, usually anything after 20%, it's almost we consider it not functioning. Unless there's a blockage that we might help relieve in order for the kidney to get better. But if there's no blockage, then there's unfortunately nothing that we can do about that kidney. That kidney is just developed in a way that it's diseased. So sometimes if it's not causing any problem, we leave it alone. If it's causing problems like pain, recurrent urinary tract infections, high blood pressure could be because sometimes there's some hormone levels that are released in the kidney that might influence the blood pressure. Then sometimes we recommend even removing that kidney if it's causing problems and has low function.
For those blockages that you mentioned, what are some procedures that relieve them?
So it depends on what kind of, so if we're talking about a blockage in the ureter, so we have to determine what the cause of it. There are certain studies that we do. There are cameras that we can go up to the ureter to see what's going on. If there's narrowing of the tube, the ureter, we can actually open it up, whether dilate it by something called like a balloon dilator, or sometimes we have to even, if it's a scar tissue, we can laser or cut the scar tissue with a small endoscopic knife. Or if it's something that's very severe and it's not dilating with these things that I mentioned earlier, we can even go surgically cut that part where it's narrow and connect the ureters again. If it's something that's a stone, then we treat the stone. If it's something that's a tumor, then we have to remove that tumor. And sometimes, depending on what the tumor is, if it's something cancerous, then we have to obviously um, discuss whether removing the kidney or all of it or not. There are many ways, there are many reasons of why the kidney could get blocked, but these are the most common.
Okay. Thank you so much for taking the time to answer all these questions, Dr. Sheckley. For
Of course.
anyone who has any remaining questions, our email has been sent frequently in the chat. Please reach out to us. We're more than happy to answer. And we're going to actually move on to the next slide, please.
So, Alicia, I
Yes.
think there's a question about the PKD and getting a kidney. So, first of all, I think the question was how do you get a kidney when you have PKD? So I think it's not when you have PKD. If you have any advanced kidney disease, ESKD, transplant is the best option. If you are medically fit for getting one, and most of our patients are, especially with PKD. So what I would tell this person who's asked this question, we'll have an upcoming chat on this, and if she has any specific questions, she can email us, and we can connect her with some of our core kidney ambassadors. But I do want to say with Dr. Sheckley, I think one of the best presentations I've seen. Thank you very, very much, Dr. Sheckley. And if somebody wants to
Thank
reach
you so much.
can we, how do they make an appointment? You're on the East Coast, obviously, but can you send us your information to make appointments?
I will, yeah, absolutely. But I really think UCLA is one of the best centers as well for urology. So I'm pretty sure my colleagues there are very capable of seeing most of these presentations. But yes, absolutely. I mean, if you're ever in the East Coast, New York or New Jersey, we're here, located right across town from Manhattan. So absolutely, Alicia, maybe he can send my information. I can send it to you.
Absolutely.
Yeah.
Yes.
Very good. And this is being recorded, so we will post it on YouTube. I know there's a lot of questions still coming in. So if you have more questions, please let us know. And I'm sure Dr. Sheckley would be back soon to answer those. So
Yeah, more than happy to.
okay, thank you.
Absolutely.
Thank you.
Thank you so much,
Thank you
Dr.
so much.
Rastogi.
Thank you for having me.
Of course, Dr. Sheckley, it's our absolute pleasure to give you a little bit of a platform to speak so much on your expertise. Thank you. So, to move on now, we would like to wrap up our presentation by highlighting one of our anticipated events of 2026, which will be the Core Kidney Health Fair at Pico Union on March 7th. This is called the Gift of Life Health Fair, and it will be taking place at the Graph Lab in Pico Union in collaboration with Big Sleeps, also known as Mr. David Velasquez, who is in need of a donor currently. And this will be in recognition of Kidney Health Awareness Month. So at this event, we're going to have many, many resources and live entertainment to offer to the community. That includes kidney health education. We will include different variants of screening opportunities for those who are in need, such as blood pressure and more. And we are very excited to engage with this community and give what we can back to the people that help us become so impactful and influential as we are. So please come out to this event, and we're more than happy to see you there. Next slide, please. And as always, if you have any questions at all, need to be referred to a nephrologist or any type of doctor here at UCLA Health, please refer to our contacts. We are very, very prevalent on social media as well. We are posting continuously for our upcoming monthly chats, as well as more educational materials on our Instagram. Our email is open, and so is our phone number. Please reach out. We are always responding and more than happy to facilitate any conversation that is necessary for you. Next slide. And thank you once again for attending. We would not be here without our attendees and the people that make the Core Kidney program possible. So thank you so much for attending, and we hope to see you next time and have a great evening.